Hello everyone, my name is Neha Tahir. I'm a third year internal medicine resident at Chicago Medical School, Rosalind Franklin University, practicing at Northwestern Hospital. I'm here today to discuss a case of myasthenia gravis induced by Nivolumab, a checkpoint inhibitor currently being used in various carcinomas, and in our case, it was used in a stage 4 esophageal carcinoma. Checkpoint inhibitors are a class of immunotherapy drugs that target different cell proteins including PD-L1, PD-1, CTLA-4, and they have been widespreadly used in clinical practice. However, there is also a concern of various side effects that can be life-threatening. So let's dive into this case of Nivolumab-induced myasthenia gravis. A 76-year-old man with a prior history of metastatic esophageal carcinoma presented to emergency department after a mechanical fall and head trauma. Before the presentation, he was having difficulty keeping his eyes open for the 2 weeks and therefore underwent an outpatient MRI brain with and without contrast, which did not show any acute changes. Prior to starting Nivolumab, he was on a standard chemotherapy, but because of intolerance, particularly neutropenia, he was switched to Nivolumab. Vital signs at presentations were unremarkable, except noticing of mild bivascular crackles on lung examination and bilateral ptosis. Neurological examination was performed and no focal neurological deficits were noted. Lab work was also unremarkable. CT brain was obtained given history of fall, and it showed scattered areas of subarachnoid hemorrhage involving frontal and temporal lobes. Neurosurgical team recommended no surgical intervention given small areas of the bleed. During the course of hospitalization, patient developed acute hypoxic hypocapnic respiratory failure, worsening bilateral ptosis, ophthalmoplegia, and generalized weakness, and at that time a preliminary diagnosis of myasthenia gravis was made, and patient was then transferred to intensive care unit and subsequently intubated and mechanically ventilated. In addition to sorting the workup for myasthenia gravis, given history of Nivolumab use, several other paraneoplastic and autoimmune condition workup was also sorted and is shown in the lab work. Lab work came positive for anti-smooth muscle antibodies and anti-titin antibodies, and hence patient was started on pyridostigmine and high-dose prednisone therapy. After completion of this therapy, patient was started on intravenous immunoglobulins and plasmapheresis. At that time, a decision was made to pursue muscle biopsies and electromyographic study, but patient family declined given worsening of the clinical situation. Post-therapy, patient was able to semi-open his eye, but he did not qualify for extubation. Hence, goals of care were discussed with the family and a decision was made to discharge him home with comfort care as per family wishes. Why it is important to discuss this case? As you know that in advanced cancer treatments, a lot of times immune checkpoint inhibitors have been used and they are actually getting as a standard of care treatment in several cancers. Nivolumab, a monoclonal antibody that blocks PD-1 inhibitor, which is expressed by T cells from binding into the ligand, can induce a lot of immune-related adverse events such as hypothyroidism, adrenal insufficiency, interstitial pneumonitis, colitis, diabetes, liver renal dysfunction, myositis, and myasthenia gravis. Diagnostic workup in this case should include acetylcholine receptor antibodies, muscle-specific antibodies, and also sometimes CSF analysis because these side effects may show an unexpectedly high CSF count. Other diagnostic modalities that can be sought include medical imaging or electroneurography and muscle biopsy. The treatment of immune-related myasthenia gravis is discontinuation of the medication along with initiation of the low-dose corticosteroids and pyridostigmine as in our case. However, in severe cases, plasma exchange and IVIG are recommended. Although immune checkpoint inhibitors' exceptional efficacy has transformed the treatment of many cancers, as we discussed earlier, but it comes with a potential lethal immune-related side effects. And for that reason, a multidisciplinary approach, including involvement of a neurologist to monitor patient on Nivolumab, is highly recommended so that it can reduce morbidity and mortality. Thank you.